This is Kimberly Hardwick, and I am presenting on fecal immunochemical testing for the screening of colorectal cancer in patients in primary care practices throughout Montana. A brief background on colorectal cancer. Colorectal cancer is the third most common cancer worldwide, and it is the second cause of cancer death in the United States. The incidence of new diagnoses in the United States for 2017 is estimated around 135,430 cases. 500 of those new diagnoses will be made in Montana. 2 out of 5 cases of colorectal cancer diagnosed in Montana will be in early stage. With the remaining 3 out of 5, they will be diagnosed in late stage, often with metastases. Primary care providers are vital for initiating colorectal cancer screening. Early identification is imperative to reduce morbidity and mortality. Primary care providers need awareness regarding the presence of blood and stool, which is a hallmark sign of colorectal cancer, but it is not exclusively indicative. Advanced practice registered nurses practicing in all disciplines of healthcare throughout Montana are responsible for assessing patient risk and recommending screening. There are lots of challenges experienced by Montana APRNs with providing education to patients due to patient receptibility. Montana has a large population of older ranching and farming communities, with stoic and conservative individuals who may be reluctant to discussing the risk factors, behavioral factors, signs and symptoms, and screenings for this devastating disease. Nevertheless, providers need to facilitate and incorporate screening supported by national guidelines. Specific barriers to screening throughout Montana include, but are not limited to, a lack of colonoscopy services in rural areas, geographic locations requiring large travel distances to large Montana cities where the colonoscopies are performed, and screening for colorectal cancer was historically performed by fecal occult blood testing. This test had low patient adherence due to prep and the requirement of collecting 3 different samples from 3 different bowel movements. The American College of Gastroenterology published recommendations in 2009 for patients to screen with fecal immunochemical testing, or FIT. FIT is performed by the patient at home and it is patient friendly. It is a non-invasive test requiring only 1 sample. In addition, FIT is superior to fecal occult blood testing because it only detects human hemoglobin originating in the lower intestine. It does not detect animal blood from dietary sources, so patients do not have to abstain from eating meat prior to testing. Food and medications do not affect the test results either. Therefore, this is an easier test for patients to complete. FIT is only for average risk patients, and high risk patients should not be screened with this. FIT steps include the primary care provider educating patients on screening recommendations, potential risks, and benefits. FIT kits are provided to the patient to take home during an annual exam. The following steps are performed at home by the patient. Step 1. Retain a small amount of feces after a bowel movement, either in the toilet or on toilet tissue. Step 2. Unscrew the cap from the collection tube. Next, collect a small sample of feces onto the grooves of the collection wand, which is attached to the cap, by poking the wand into the feces a few times. Be sure not to collect too much though. The wand should not be overly coated. Step 4, place the wand back into the collection tube and screw the cap on tightly. The patient can now dispose of the rest of the retained stool appropriately. And lastly, place the collection tube into the pre-addressed. Supporting evidence for the use of FIT from the American College of Gastroenterology consists of replacing guaiac-based fecal-occult blood test with FIT due to patient adherence and superior results. Additional research supports the use of FIT for screening all average-risk adults who meet screening criteria. This criteria will be discussed on the next slide. Colonoscopy, however, remains the gold standard for screening all. How do you identify average risk patients? Average risk includes patients over the age of 50 without a pre-existing diagnosis of colorectal cancer. Patients without a history of blood in their stool. This includes hemorrhoids, inflammatory bowel diseases, including Crohn's, diverticulitis, to name a few. And if a patient is African American, then the FIT really should begin at 45 years of age due to the higher incidence in this population. Any patient opposed to colonoscopy should also be offered FIT. Research from Wang, Qing, Chang, and Sung revealed that younger men are more willing to screen with FIT compared to older men. And 41% of men in their study chose FIT. However, 43.7% of men in the study chose colonoscopy, which seems contradictory. However, the authors discussed that the men who chose FIT did so because they refused. High-risk patients should not screen with FIT. The determination of high risk should be determined clinically. However, the following three criteria mandate screening with colonoscopy. Please note that a patient only needs one of these criteria: a previous diagnosis and treatment of colorectal cancer, a positive family history of non-polyposis colorectal cancer, or Lynch syndrome, or a positive microsatellite instability test. Additional high-risk characteristics need to be carefully considered by the clinician for the appropriateness of FIT versus colonoscopy. African American individuals, male gender, obesity, tobacco use, HIV-infected males, family, adenomatous polyposis, inflammatory bowel diseases, prior history of radiation to the abdomen or pelvis, or a history of endometrial cancer at a young age. Sensitivity and specificity have been established through multiple research studies. A meta-analysis of 19 studies performed by Lee, Lyles, Bent, Levin, and Corley found the sensitivity of FIT screening by pooled analysis to be 0.71 with a 95% confidence interval. Specificity was found to be 0.94 with a 95% confidence interval. In addition, the meta-analysis concluded that sensitivity and specificity are similar between FIT kits processed at professional labs. However, patients requiring education regarding delay of mailing samples, as sensitivity can decrease by hemoglobin degradation and exposure to high temperatures. FIT detects approximately 71% of patients with true disease by specifically identifying human hemoglobin in stool. FIT does not detect partially digested hemoglobin from upper intestines. Therefore, FIT is only applicable to screening the colon and rectum. Just to reiterate, FIT does not detect hemoglobin from diet. FIT screening is significantly less expensive than screening by colonoscopy. Colonoscopy costs several $1,000s per procedure, while FIT kits cost approximately $26 each plus laboratory processing fees. Health benefits include the early detection of colorectal cancer, which ultimately reduces morbidity and mortality. Risk involved with FIT screening includes a false positive. This can result in psychological harm to the patient and increased workup, resulting in increased costs. If a FIT screen is positive, the following steps should be performed. Follow up with a high-quality colonoscopy. This allows a specialist direct visualization of the rectum and colon. Polyps can be discovered and oftentimes completely removed at the time of colonoscopy. Biopsies of polyps or lesions can be formed if they're too large to remove, or non-malignant sources of blood can be located and assessed. Polypectomies, the removal of a polyp early in development, benefits patients as most edematous polyps average 10 years to develop into a malignant. Practice recommendations are provided in national guidelines for low risk or high risk patients. Recommendation for low or average risk: begin annual FIT screening at the age of 50. Discontinue annual screening when a patient's life expectancy is 10 years or less because the risk outweighs benefit. If a low or average risk patient refuses FIT screening, offer sigmoidoscopy every 5 years, or computed tomography every 5 years, or FIT DNA multi-targeted stool DNA test every 3 years. Continue to offer screening to your patients even if they refuse, as patients may change their minds or need time to consider screening options. High-risk patients should not receive FIT screening. They should screen with colonoscopy. The following patients should only receive screening by colonoscopy: those with inflammatory bowel disease, a prior history of colorectal cancer, a first-degree relative with colorectal cancer, prior history of abdominal or pelvic radiation, and those with a prior history of. In summary, FIT screening for colorectal cancer should be offered annually by primary care providers, including advanced practice nurses, for average risk patients over age of 50. FIT is non-invasive and cost-effective. No prep is involved, and the sample is collected in the patient's home. FIT has high specificity and sensitivity, but does not identify the cause or source of hemoglobin present in stool. FIT is recommended by the American College of Gastroenterology, the Centers for Disease Control, and other professional organizations. Appropriate screening tool for use throughout Montana to limited colonoscopy services is FIT. Also, travel and distance barriers, underinsured, or patients with high deductibles could benefit. References are included here. Please contact me with any questions regarding this presentation. Thank you.